Hi, everybody. Welcome to everyone who's joined us on this inauguration day. I'm Eric Bruns. I'm a professor in the School of Medicine at the University of Washington, and I'm here with research scientist Dr. John Olson, and we're both representing the University of Washington's Wraparound Evaluation and Research team. We are joined by Kim Estep and Kim Coviello from the University of Maryland, Baltimore, School of Social Work. And we are all part of the National Wraparound Implementation Center and National Wraparound Initiative. And so we're really pleased to have you here. We're going to be presenting a webinar on some recent research that we have completed, asking about the impact of system factors on wraparound implementation and the wraparound workforce, wraparound Fidelity. So just a couple pieces of housekeeping before we get started. I'm also starting us in kind of slow here so people can join and get settled. So please know that the recording of this webinar will be available afterwards. Usually takes a few days or a week, but they will be available on the website of the National Wraparound Initiative, which is nwi.pdx.edu. Maybe Nick can put that into the chat for folks if folks aren't familiar with the National Wraparound Initiative. We have a section on our website, which is hosted by Portland State University, that has all of our webinars going back at least 10 years. So second piece of housekeeping, obviously with, over 100 folks, we're not going to be doing any introductions or screen or video chatting. So please, if you have questions or comments, put them into the chat and we will field them at a couple different junctures along the way here, as well as at the end. We'll probably be presenting and discussing the implications of our findings for about 40-45 minutes, and then spend as long as is needed. We can go past the top of the hour, but we'll try and get to some of the questions and comments after we're done. Everyone is going to be muted throughout the presentation. Yes, so please use the text box or the chat box to ask any questions. All right, let's get going here. So we decided to do this webinar focused on this particular research project for a few reasons. First, the study, we were really proud that this was selected as just one of a few behavioral health focused studies from many hundreds that were submitted to the National Dissemination and Implementation in Healthcare Conference, which was held virtually, sponsored by the National Institute of Health and held virtually back in December. But the D&I conference, the annual D&I conference, as it's referred to, the registration costs, over a few $100s, and we were only given 10 minutes to present. So we figured it'd be a good idea to get this information out there in a more accessible fashion. So hence doing a webinar for the NWI. More important, this is the important and fun part of our jobs as researchers, as trainers, technical assistance providers, when it comes to the data at least, translating the science of what we're doing into recommendations for systems and programs serving youth and families. This is the way we're going to have the biggest bang for the buck of our data collection in some ways, is to make get the implications out there for the field and hopefully influence policies and financing decisions going forward. Given that this is Inauguration Day, the topic of looking at system factors seems particularly relevant. The last time we had a new Democratic president, laws were rapidly passed in the subsequent couple of years that had huge implications for children's health and mental health, including the Affordable Care Act, the Child Health Insurance Program Reauthorization Act. These bills are arguably the most influential behavioral health pieces of policy in our lifetimes, right? So they expanded the number, or at least in the last 20 years, expanded the number of children covered by Medicaid. They gave rise to all sorts of new financing and quality assurance mechanisms. And a lot of them focused on, the young people and families that we work with, the individuals with complex needs. So today we're going to be presenting results of a study that reinforce just how important such policy and financing factors are to achieving high quality services for youth and families, including maybe even more relevant to complex multimodal strategies like wraparound than other evidence-based practices. And on that note, do go back and check the webinars for our presentation on the recent meta-analysis for wraparound, which really does kind of demonstrate that wraparound truly does have a good basis and evidence for effectiveness. Go ahead to the next slide there, John. So this study also directly informs our quest at NWIC to provide the highest quality training, coaching, and technical assistance that we can. So NWIC relies on lessons from dissemination and implementation science. And one thing that's been often observed is that the effort that is taken to make high quality implementation and outcomes happen is on a continuum. And it's up to us to kind of find a place at the highest level of that continuum possible if we want to get outcomes to occur. So if you just generate information on what's needed, that's just diffusion, right? That's just letting whatever is going to happen, happen. It won't get to high quality implementation. You can go a step further and do targeted dissemination. So instead of just kind of letting the information diffuse out there, you can do targeted conferences, trainings, presentations. That's called dissemination. That might help implementation happen. But if you really want to get to fidelity and outcomes, you need to embrace full multi-tiered implementation support at the practice level, at the program level, at the systems level. And this means hands-on coaching and technical assistance at all of those levels: practice, organizations, policy and finance decisions that the policymakers make. And that's when you can truly make it happen. And implementation science really does increasingly show that if you don't get to that level of making it happen, you're going to have services as usual, which are not going to be any more effective than the evidence-based practices are not going to occur, and the outcomes are not going to be any better than services as usual. So we've got to take ourselves at an implementation support level to that full implementation level. Go ahead to the next slide, John. So for many years, arguably since Beth Struhl and Bob Friedman wrote the first monograph on systems of care, researchers and leaders have known that implementation depends on getting the conditions right in systems and programs. And in the last 10 or 15 years or so, implementation science, didn't invent these ideas. It just comes along to provide a language and some more theory and research, a lot more theory and research on these topics. So for example, the exploration, preparation, implementation, and sustainment, or EBPs framework, presents specific factors at all of these levels. In implementation science, we refer to the systems level as the outer context. So it's a lot more than just child-serving systems. It's, the political system. It's the demands of the public, for example. Then there's the inner context, or programs, over here to the right. Leadership, the quality and fidelity monitoring that goes on, and so forth. So that's one framework that we rely upon at NWIC. Go ahead to the next one, John. The next slide here shows another framework that we rely upon at NWIC, the Consolidated Framework for Implementation Research, or CFIR. So this presents how outcomes are influenced by fidelity and implementation success. So you got outcomes on the right, measures of fidelity and implementation are there in the middle that influence outcomes, and all sorts of factors, again, at the system, program, intervention level, as well as the characteristics of practitioners themselves and the process of implementation that we use to try and get the program implemented. These all influence implementation success and thus outcomes. And so anyway, the EBPs and the CFIR are just two of over 70 implementation frameworks that have been found in the literature. And this gives me the opening for my favorite implementation science joke, which is, why are frameworks like toothbrushes? Because everyone has one and no one wants to use anyone else's. Ba-doom. Okay, go ahead to the next slide. So let's set up our study we're going to talk about here and its implications for wraparound, right? So regardless of which framework you like, or maybe you've developed one, there are some pretty consistent domains, including system factors, organizational factors, implementation process, fidelity, and outcomes, right? That's pretty consistent across our implementation science frameworks. So to make sure we're paying attention to all those things, the systems, the financing, that's the outer setting, organizations or programs, the inner setting, the characteristics of the intervention, such as wraparound or the evidence-based practices we need in the service array, the characteristics of the practitioners themselves, and so forth. We here at UW-WIRT and the National Wraparound Implementation Center, along with lots of colleagues like Janet Walker at Portland State and others, have developed or applied a whole bunch of measures at all of those levels. So I'm not going to go into detail. Some of these are in our study here, but the point is that we've got measures across all of these levels, and these measures don't just help us stay on track in our training and technical assistance as we work with states and jurisdictions. They also provide an opportunity for us to do research that isn't just going to inform our work or even the wraparound field, but also implementation science and systems of care. So go ahead to the next slide there, John. So this brings us to today's presentation and research. So because we have data at all those levels in our work that we do at NWIC, we are able to do natural experiments that compares different kinds of situations. And today what we're going to look at is decisions and the impact of the decisions that are made at the state level on how states are going to organize and pay for wraparound care coordination. So NWIC has worked with over a dozen states over its existence. And some of these states have invested in a care management entity approach to providing wraparound, getting the services delivered to those youth and families with complex needs. So care management entities, and it might be good for Kim or someone to put a little link to the primer on CMEs that was developed so people can go find that and have it pop up in their web browsers, because it's real important stuff. And this study shows how important it is. So care management entities are nonprofit organizations or public agencies, and they serve as a centralized locus for working with complex needs populations. And they're very different than other methods of getting things like care coordination or case management done. These entities can contract with and manage the provider network themselves. They hold the contracts with providers who serve their complex need individuals. They provide training, coaching, and supervision for practitioners that are specifically trained to do care coordination. Sometimes they also involve parent and youth peer support right there within the CME. And they're focused on providing this type of care and working with others in the service array to get the individuals whatever they need, make it happen as wraparound is supposed to do. Alternatively, a lot of states also just rely on, community mental health centers or other entities that are typically outpatient mental health providers, and they provide an array of services. They don't specialize, and they don't receive a case rate typically for doing this work the way many CMEs do, so that care can be more flexibly delivered because you can do whatever it takes under that case rate for an individual. So that's today's study, CMEs versus CMHCs, and how much does it matter? Go to the next slide, please. The next slide shows a picture that a lot of folks in this room probably have seen. So this is a depiction of the CME structure for Wraparound Milwaukee, a whole county in Wisconsin that has all of its youth with complex needs, whether they're in juvenile justice, child welfare, mental health. Usually it's several of those. So many years ago, Bruce Camrat and his colleagues recognized that why do we have silos that are serving these kids that all have complex needs, but very similar in terms of their complexity of needs in different silos? Let's pool all those funds. You can see the contribution from each of those sources, Medicaid, mental health, juvenile justice, child welfare, and create one entity that specializes in doing this and just this. And they contract with a provider network of 210 providers. They contract with Families United to do parent-to-parent peer support. And they are responsible for doing whatever it takes with a case rate to make it happen for these youth and their families. Go ahead to the next slide. So going back to our framework, you can go ahead and animate this, John. CMEs create a very different kind of context, different kind of leadership. Funding and contracting, it's very different. They contract with providers of EBPs. They have a case rate to do this work. And on the intercontext side, CMEs create a very different way of which the organization that's doing care coordination works. They have much more assiduous quality and fidelity monitoring. They have units that are just focused on care management and not on a whole bunch of other things. So it creates a big difference whether you look at it just from a systems of care perspective or an implementation science perspective. And that's the jumping off point for our study. And with that, I'll hand it off to John to talk about the research.
All right, great. Thank you, Eric. So with that introduction, I'm going to describe really what's a series of 3 highly interrelated studies that focus on some of these differences across the CME and CMHC structures that Eric discussed. So I'm just going to jump into some of our hypotheses. I'll go over some of the methods we used and then talk about the results, pausing here and there so Kim and Kobe can jump in, and then we'll tie it all together at the end and answer questions as we go. So our main expectations or hypotheses that we had for these different studies were that we expected differences across the CMEs and CMHC states in terms of implementation outcomes related to wraparound. Specifically, we believed that the CMEs would be able to implement wraparound more completely. We figured that implementation would be faster in terms of the level of completion being one piece, but then we'd also get there a little bit faster in the CME structure because of the nature of the underlying inner and outer settings. We also believe that we get better fidelity or more adherence to that underlying wraparound implementation model with the CME model. With both the CMEs and CMHCs, so this is hypothesis number 2, or at least the second grouping of hypotheses, we believe that the implementation duration would be higher for wraparound regardless of administrative structure compared to other manualized EBPs, largely because wraparound is a systems level intervention. There's more complexity there in terms of implementation. And then we also looked at some training outcomes, kind of getting at that inner setting of how we can support the workforce to actually implement wraparound. And we felt that the CMEs would be structured such that those that are attending the trainings would come out with better outcomes than those in the CMHC structure. So let me jump into that a little bit more deeply in terms of how we did some of our measurement, and then I'll get into some of the results. So we had 3 main measures that we used. The first, looking at implementation progress, and we used an adapted version of the stages of implementation completion, what we call the SIC for short. This was designed by Lisa Saldana and her group out at the Oregon Social Learning Center. And we worked with Lisa and Lisa's team to adapt the stages of implementation completion to be wraparound specific. And we'll go over a few details of what the universal SIC looks like versus some of the pieces we've added and modified slightly to fit with the wraparound model. That said, it's a validated instrument, and we can make some comparisons across the wraparound and other manualized evidence-based practices that are out there. We also looked at implementation fidelity using the coaching measure for effective teams. Those of you that are on this webinar today that have worked with NWIC are likely familiar with a COMET, as we call it, to look at the implementation fidelity outcomes across CME and CMHC states. And I should also mention, we had 4 CME states, 4 CMHC states. With the exception of this, we had an extra CME state that we have implementation fidelity for. And then finally, training impact. Again, many of you will be familiar with this measure, the IOTA, or the impact of training and technical assistance measure. This is a measure that we use for any of the NWIC trainings. It gives some information about the quality of the training, what people are doing with the training, and I'll talk a little bit more about that in a moment. And again, we have 8 states, 4 CMEs, and 4 CMHCs represented with the IOTA data. So let's start with the stages of implementation completion. Stages of implementation completion assesses, as the name implies, it looks at different stages of implementation. There are 8 stages, ranging from engagement all the way through competency. I won't go over all the details here. You'll have these slides available to you, so you can take a closer look. But the first three stages are pre-implementation. That's engagement, feasibility, readiness planning. Then you move into the implementation phase, which are 4 through 7, so things like hiring staff, monitoring fidelity, and so on. And then finally, you get to competency at stage 8, and then ultimately to sustainment once we have implementation in place, to then sustain that over time. And within each of these stages, there are a variety of tasks. And we'll go over some of that as we go through the data so you get a little bit of a sense of the types of things that we're tracking with the stages of implementation completion measure. There are a few different ways of aggregating the data. One is simple completion. So here's the first slide of data. And this bar chart, I believe you'll be able to see my cursor here. We have a percentage, simple 0 to 100%. And then across all of these slides, I will have our CMHC states represented in, depending on your screen and screen colors, somewhere between a dark blue to a purplish kind of color. And then the CME states will be orange. And you can see in this bar chart that across really the first 5 stages, there's almost 100% completion for both CMHCs and CMEs, okay? It starts to drop off a little bit as we get to stage 6. So the later end of the implementation stages, you see a drop off where states are not completing quite as many tasks at that stage as they were earlier on. And that's a little bit more exaggerated for the CMHCs than the CMEs. And that's really what we expected. Our first hypothesis was that we would see a little less completeness in those CMHC states. Now, if we move to another way of looking at the data, things change a little bit. This is time to completion. So while the previous slide showed that most states are getting to completion across at least the first 3/4 of the stages before we see some drop off, there's a lot more variability here in time to completion. Now we know Wraparound is a complex set of implementation processes. So we expect it to take time, but this slide really demonstrates the disparities across the CMHCs and the CMEs. Early on, not a lot of time in stage 2 or 3. These are all in months. So we're looking at several months to half a year. But then it starts to really grow as we get to stage 3 and beyond. And you start to see the discrepancies across CMHC and CMHCs and CME states really start to deepen. Stage 4, almost twice as long, 26 months compared to 13.5 months. Stage 7 is another one where we see the twice as long, 52 months. We're talking years to get through this particular stage. As compared to in the CMHC states as compared to the CME. So we really see some of those differences at that point. Now, the next slide, I look at just a sampling. We don't have the time today to go in depth across all the different stages, but I want to give you a little bit of an idea of the types of things we're tracking within each of these stages. I'm going to go backwards for a minute. If we look at stage 7, again, that's where we see these really big discrepancies. We can start to look at some of the reasons for those discrepancies here at the item level. So if you look down, these are again just months. If you follow my cursor down for CMHC states, every single item here takes longer in the CMHC than the CME. And I highlight a few where it takes a particularly long time. So this starts to really explain how we go from a few months to many months, or years in many cases. Where these states start to get hung up a little bit in the wraparound processes. Fidelity data, matching the fidelity data across national and local coaches, maintaining workforce stability and competence. And one caveat in all these data are that the sick, when we score the sick, when there's an item that's missing, we drop that item. So if anything, these are somewhat conservative estimates. In some cases, especially when we get down here to demonstrating workforce stability, we have a variety of states that never quite achieve that. Now, it doesn't mean implementation doesn't happen. We can skip ahead, right? With the sick, you can do stage 7 before finishing stage 6, but it does mean that this is taking a significantly long time, and sometimes it's something they're continuing to work on. Even though Wraparound is fully implemented, some steps along the way have been either skipped or have taken, like I said, a very long, considerable amount of time to be put in place. Okay. So let me move on and look at the data yet another way. And this is really looking at time to completion still. But now I'm looking at the pre-implementation phase. So this is stages 1 through 3 of the SIC versus stages 4 through 7. And we see that we have, again, the CMHC states are taking longer, 21.8 months compared to 13.7 months. But we can now compare this to a normative data set. The benefit of using a validated instrument like the SIC is that it's been used across the United States. So we have this normative database of general evidence-based practices, other manualized evidence-based practices that are out there. And you see that wraparound takes significantly longer at both the pre-implementation and even more so at the implementation phase. Now, this particular slide, we're comparing apples to apples. So I'm looking at only universal SIC items. If you remember before, I said that we also have added additional items onto this that are wraparound specific. So I'm going to turn to that slide in a moment, but I'm going to let Kobe jump in really quickly just to give a little sense of some of those items on the SIC.
Yeah, thanks, John. We just wanted to make sure that everybody kind of understood what are some of those universal items. And so really paying special attention to some of the items in pre-implementation. So if we're thinking about, for example, phase 1, which John showed us on that graph, that would be engagement. And so some of the things that we're assessing there are very basic. So basically when you're thinking about a site reaching out to learn more information about an EBP or a practice model, really tracking the date that interest has been indicated. Also kind of tracking when maybe they reached out to get an initial cost of, kind of what a scope of work would look like for working with a purveyor. When you're thinking about the next phase, which would be stage 2 or feasibility, that's really about considering kind of when, what is that sort of plan going to look like? When was the first time that the state or the system developed a plan? When was the first time that they brought stakeholders at all levels of the system or workforce together, especially leadership, to have some of these conversations? And then finally, looking at phase 3, which is readiness planning. Again, are we taking time in advance of implementation to really think about the funding plan, our fiscal structures, what our referral criteria is going to be, et cetera, and so on. So really kind of thinking about what is that written implementation plan going to be, and how are we going to fund this moving forward, not just for the implementation period, but beyond, so that this will be sustainable. So those are just a few examples.
Yeah, great, thanks, Kobe. So, and that's what I said, and on this slide, we're really looking at those universal, the common items across. Now, when we add in some additional items, which Lisa's team allows us to do, it doesn't put it into this score. So I calculated our own scores when we add in some wraparound specific, and hold tight for a moment. I'll talk about which items those are in just a moment. But what you see is a real jump here. Data change a little bit. At pre-implementation, you see a narrowing of the differences between, at pre-implementation between CMHC and CMEs, still more than the universal normative database. But at implementation, it becomes striking, right? 121 months, we're talking a decade here to get all those pieces in place. And again, I want to give one caveat. That doesn't mean that implementation isn't happening. It doesn't mean that wraparound's not happening, but it means some pieces have been either skipped ahead or they've continued to work while implementing parts of the wraparound, but some things have been missed along the way. So we get to this kind of years in the making on this particular slide. Now, to understand a little bit, here is a list of, I say examples. This is actually the bulk of the new items we added to the SIC that we've added on that are wraparound specific. Don't have time today to go over every one of them, so I highlighted in orange those that really seem to take the longest amount of time. So really quickly, the trainings, what we're seeing is that the basic beginner training is being implemented right away, but it's taking a long time for sites to get to those intermediate and advanced trainings. Establishing a CQI plan seems to be taking a very long time. Getting the plan of care to represent the locus of planning for all systems and provider orgs within the system of care. and then also getting that stable workforce. And we saw that earlier when I highlighted that stage 7, that stable workforce piece is something that these sites, excuse me, a lot of states and organizations are really struggling with. Okay.
And John, before you move on, I just
go
wanted to
ahead.
comment on that first bullet you mentioned around the engagement and advanced training. Because again, I think that, oftentimes you're right, folks do move through those initial trainings very quickly. But the reason that we might hold off on doing an intermediate or an advanced training really has to do with perhaps the gap between attending those initial trainings and beginning to implement the practice model, and beginning to, again, refine and grow some of those skills or demonstrate those in practice. So we wouldn't necessarily want to move forward with training more intermediate or advanced skill sets without ensuring that folks do have those basics and are actually beginning to practice.
Thank you.
Yeah, and I might jump in real quick just to reinforce something that John and Kim or Kobe both referred to, which is, let's be clear that these are indicators of extremely high, rigorous levels of accomplishment in terms of implementation of evidence-based practices when it comes to the EBPs in general that have used the SIC, and Wraparound when it comes to all of those stages of implementation completion items, as well as these ones that we've added. The meta-analysis we recently completed of 17 controlled studies that found significant, more positive outcomes for kids for Wraparound, certainly the majority of those programs in that meta-analysis would never have lived up to these kinds of indicators, any more rapidly than this average of, potentially 4 or 5 years of getting to full implementation. So let's be real clear. We are at NWIC, we are shooting for the highest level of implementation accomplishment possible, because we know that that's what it takes to really fly and to get really great outcomes. But it doesn't necessarily mean, like John said, that implementation wasn't happening even as the process was unfolding, sometimes a decade or more. And if you're in one of those states, this is an ongoing process, and it takes a long time to get to sustainment and workforce stability and so forth.
All right. Let me keep us moving forward. In fact, I'm going to give it back to Kobe for a minute to talk about the COMET. The next set of data slides that I want to talk about are focused on our fidelity measure. So let me pass it to Kobe, who lives and breathes the COMET, and just describe briefly, and then I'll go into some of the findings that we have related to our fidelity data.
Thanks, John. I do live and breathe the COMET. And so just to reiterate, the COMET is one of the coaching tools that we utilize. It stands for the Coaching Observation Measure for Effective Teams. The COMET is a tool that embodies 46 items and is used to really assess skill development of care coordinators or wraparound facilitators. And when you're thinking about the COMET, it is distinctly different from the wraparound fidelity tools that we use. The COMET really digs deeper into the skill sets and how those skill sets are actually being demonstrated, whether it be in documentation, in observations of what's happening in the field, child and family team meetings, and again, is looking deeper at the quality of practice, not just the fidelity of practice.
Okay, great, thank you. So with that, I'm going to jump right into some of our data slides. Again, we still have the same bars for the dark bar for CMHC and the orange for CME. And what you see here across the different subscales of the COMET and the total score, so we have the subscales first and then the total score at the end, you see higher fidelity scores, higher COMET scores across the board for each. And these are statistically significant, the differences at each level. The CMEs demonstrating higher scores compared to the CMHCs. And again, I'm going to pause right away and let Kobe come in to interpret a little bit. Then I'll jump into some of the deeper analyses that we've done.
Yeah, so I think that this data is actually really, really interesting because when we're thinking about the COMET and we're thinking about installation of wraparound, whether it be in a CME or a CMHC structure, we need to remember that when staff are learning wraparound, most of them are kind of starting at the ground level. Folks don't necessarily come in knowing or understanding or able to apply the skills that we're looking for in wraparound. So I think it's important to remember that, especially when you're kind of looking at these scores. and where even within the CMEs, we're not necessarily exceeding that 50% mark. The other piece I think to remember is that these scores represent an aggregate. So when we're assessing staff, we are assessing all care coordinators across an organization, not just those care coordinators who are considered to be skilled or more seasoned. So assessment may happen within, your first 3 months following going to an introduction training, and it should continue throughout your duration of employment in that role. So again, this is going to have a mix of individuals at different levels of skill development. Another piece that we talked about earlier, which I think also figures into this data, is that we see that within this field, there is a great deal of staff turnover. And I think that, again, when you consider that, it makes it very tough for staff to fully be able to, learn and apply the skill sets that they're learning in a quality way. Oftentimes, it does take about 2 years for us to see staff be truly skill proficient in wraparound. And therefore, if you are unable to, maintain staff for that period of time or even beyond that, you're always going to kind of be starting with new folks who, again, are starting at zero. So I think that this data is interesting. But I think that there's also some kind of other things that we should consider when reviewing and looking at it.
Yeah, just a good segue. Whenever we look, especially looking at basic mean scores, there's always a deeper look we want to dive in to try to look at other explanations, other factors that are influencing the data, many of which Kobe mentioned in our recent project. We wanted to account for the fact that while we're seeing these basic differences in scores at the aggregate level, we realized that there's some, we say, kind of confounding factors, other factors that are at play here. The care coordinators who we're assessing are nested, they're embedded within different organizations, which are in turn embedded within states, right? So you see some clustering effects there as well. So we also, for those of you that are excited about stats, we went a little deeper and did some multi-level models where we start to control for or account for at least that kind of nesting effect. So we did a 3-level model here where we we're looking at the individuals nested within organizations, nested within states. And I'm not going to spend much time on this slide except to just point out the 2 basic findings that that we want to highlight here. The first is that despite the fact that we are now considering and accounting for that that variance across, or that kind of the pooling, the nesting, we still see a significant difference across CME and CMHC states. So we still see those higher scores in the CME states relative to the CMHC state. We also have an interesting interaction effect here, a time by structure. So that's the structure being the CME, CMHC state. That changes over time. The best way to interpret that is to actually look at a chart we have where we see, if y'all can see my cursor here, we start out at time point 1, the first year of data collection. Immediately, we have CME states are getting higher COMET scores than the CMHC states right out of the gate. Which is interesting in its own, in its own. I'll let others interpret this a little bit further. But what we see is kind of this sort of sobering reality that unfortunately we see a drop off over time. Now you see a little bump up and down. Honestly, from a statistical perspective, you'd probably consider the CMHCs to be pretty flat and the CME to have a slight downward trend. Doesn't quite get down to the kind of baseline CMHC over time, but you do see this regression over time. So I'm going to actually, Kim was going to join in for a moment here and kind of help us interpret some of the reasons why we speculate this might happen. And like good researchers, I'll always say we need to continue to track this and get more data and see if we can replicate these kinds of findings. But this is kind of the trend that we're seeing in this current analysis. So I'll stop for a moment and let Kim chime in.
Yeah, hello everyone. Thanks for joining us today. So I didn't get to say that, but welcome earlier. So this is interesting. I think we've seen these trends for a little bit, right? Which has kind of sent us on this path of this deeper dive. But I think, and what we hypothesize and what you'll learn later today and how we are trying to address it, is that really as systems are beginning their wraparound installation effort and are early in those, like you have a lot of oversight, you have a lot of involvement from the systems, organizational leadership, like there's just a lot of investment that moves beyond care coordinators and workforce development, training, coaching activities. And over time, what happens is as wraparound is installed and kind of flowing, is that we see a pullout of system organizational leadership because they feel like, you know, it's kind of working. It's, you know, things have been done. We've addressed all of those pre-implementation factors, implementation elements, and so on. But when people step back, you know, things, drift happens actually very quickly. And so this is something that we're hoping to assess and begin to tell another story around. And so this is a deeper dive that we'll talk about as we do our wrap up. But that's, you know, some of what we're thinking. And I don't know, Eric, if you wanted to add any more around that, but you know, we know that ongoing accountability is really important, and systems need to stay kind of checked in around this at the state and organizational level, for sure, for sure.
And Kim, just to add in,
Yeah,
I think that this graph also really shows just that drift happens very, very quickly if we're not attending to it. Sorry, Eric.
Yeah. Well, I was just going to say that, you know, we're pretty confident because it aligns with things that we've seen out there in the field around the difference between what kind of level of implementation success and fidelity. Soon we'll also look at outcomes that you can get if you organize yourselves in a way that's going to support wraparound, such as using care management entities. You know, we've worked with states that have worked for years and years, decades, to refine further, bring more populations in. New Jersey now, you know, does wraparound for, you know, youth with all range of different kind of healthcare needs, developmental disabilities and so forth. They're always innovating, but we're pretty confident that these data really speak to the main thing, which is how you organize yourselves at a state level is really going to influence your implementation success. For this kind of result, it really does raise more questions than it answers. And it's something that NWIC has to now contend with. Is it indeed about, you know, a little bit of complacency? Is it because system of care grants end and things change, you know, at year 4 or 5 for some of these states that use their system of care dollars to do care management entity setups and stuff? Is it a measurement artifact? Because the fact of the matter is that with our data from our Wraparound Fidelity Index and probably the comment as well, you see that as states get better at doing this, you get more complete data, which might actually suppress the scores because you're getting data on fidelity for all families, not just the ones that are easiest to get a hold of or, you know, whatever. So there could be measurement artifacts as well. We've got to do some more looking into it.
Yeah, so always more data that can be collected and analyzed. So let me jump in. And I've thrown a lot of numbers at you here. So I have one more short section here. We're going to look at some of our training data. And then I'm going to turn it back to Eric, Kim, and Kobe to interpret all of this and bring some implications for practice. But before we get to that, let me talk about the IOTA data. The IOTA instrument is a self-report survey that we use after any of the NWIC trainings. So many of you on this webinar today may have filled out an IOTA in the past. Focuses on the quality of trainings and then some self-report about items such as competence or mastery of content, impact on practice, and so on and so forth. And I just highlight a few pieces here. Again, looking at differences across CME and CMHC states. If you remember way back at the beginning, I spoke about the hypotheses we had, and we expected that the CME states would be a little bit more receptive, maybe in a place to take advantage a little bit more of some of the trainings. And we saw that in terms of competence. Those that are coming out of CME states tended to report higher levels of competence coming out of the trainings. They attended a larger number of trainings on average. However, the practice changes. This is the self-reported that, yes, we're doing changes. We're making changes based on these trainings, was higher for the CMHC states. Now, initially, that ran counter to what we expected, but when you really think about it, it makes a lot of sense that the CMHC states, if indeed the CME states are better structured, to more readily pick up and run with the wraparound implementation, you would expect those coming out of the CMHC state to perhaps say, well, we need to make a few changes to maximize our ability to implement all the different pieces and processes of wraparound as a system of care. So those are the differences we saw. They were all statistically significant, large sample here, so that the differences are not enormous, but they are significant. And again, it goes along with this, just another piece of that puzzle of looking at some of those differences within that inner setting that we see across the CME and CMHC structures. So with that, I am going to turn it back over to Eric and Kim and Covey to lead us through some interpretation and draw some implications of this work. I'll go ahead and mute myself for a little while.
And Eric, just to point out, as you go into this discussion, there's some questions in the Q&A. And so I want to put those out there because I feel like you're going to answer a couple of those as you start to walk through. And so Steve Johnson has asked, what is our theory around why CMEs outperform CMHCs, and any thoughts for states that are deeply committed to the CMHC model who are trying to take wraparound statewide in a high fidelity and quality way? So I just wanted to throw those out there so that we could work to address those as we move along.
Yeah, thanks for pointing that out. I was looking at the chat thread and didn't see that question. So I think that, you know, folks like yourself and Covey have really thought a lot about, as you've been doing training and coaching at a system level as well as at a organizational level. That's what NWIC is doing now, right? So to make it happen, you know, once upon a time, we were mostly focused on the practice model and training folks on the practice. And it didn't take too long for data and our observation to make us realize, you know, we've got to put equal, if not more, effort into how our wraparound provider organization set up to do this work as the staff themselves. It's been a long observation that, you know, what we don't want to do is burn staff out by making them be wraparound facilitators or care coordinators in a context that's not supported. They'll burn out and turnover will happen. But at the same time, we have seen pretty high quality wraparound occur, even in, you know, the context of community mental health centers, and so I think that the short answer to that question, and I'll give it to Covey and Kim to talk about more in a second, is that, you know, it probably can happen to some extent, but there are ceiling effects that are going to happen when you're organized to do wraparound out of CMHCs. But if you are doing it within CMHCs, what we've seen is that some of the states that have rolled wraparound out through CMHCs have gotten pretty high levels of quality and fidelity because they figure out ways within CMHCs to have there be units that are just focused on wraparound, that they are collaborating with providers all across the service array, not just within their own walls, to make sure that evidence-based and practices and other supports that meet the needs of the families are in their plans. So, you know, right there are two things that we see that CMHCs provide typical barriers to high quality wraparound. The workforce is doing other stuff besides just care coordination. Their supervisors are doing other stuff besides just care coordination. They're not contracting with an entire array of providers of different kinds of services that can meet the family's needs. If you can overcome those things and do really good measurement and feedback, as we have seen in some states that use CMHCs to keep on track, probably will do pretty well. But what we're observing here is that overall, the CME structure really promotes better wraparound right out of the gate, as you saw from that slide that John showed, where right at year one, they were already higher. So yeah, so that's an answer to your question. We'll talk a little bit more about that as we go along. But, you know, the bottom line here is that those administrative and fiscal structures associated with care management entities promoted more complete and faster implementation of wraparound. And then we see, you know, in one of our fidelity measures, it's really kind of a coaching measure, a competence, a skill measure, the COMET. You know, we have other measures that really are more summative, such as a wraparound fidelity index and so forth. And we're doing some research that brings that into these kinds of questions as well right now. But it's a little harder because we know we've got comment data on every single one of these states, whereas WFI is mixed, right, across our NWIC states. But the thing that's cool about the WFI is people are using the WFI in a lot of states and jurisdictions that aren't NWIC. So now we'll be able to bring WFI, wraparound fidelity index data, into asking about even bigger questions as we have done. But anyways, point being, fidelity and completion and rate of completion all were better for the states that have organized themselves with care management entities, often at a regional level. The other thing that was really fascinating was to see, because we used Lisa Saldanha's measure, the stages of implementation completion, say that 10 times fast, because they got all those data on other EBPs that are usually, you know, outpatient mental health treatments, they don't require all of these supports at an organizational and system level. I mean, wraparound is a systems transformation intervention as much as an individual family or kid intervention. So it's not surprising that wraparound takes longer. But what was interesting was being able to see just how much longer. And, you know, it wasn't like, for CME states in particular, it wasn't like 3, 4, 5 times longer. It was about twice as long. And then the CMHC states, much longer than a typical EBP. So it was cool to be able to look at all of those different comparisons. But yeah, that last bullet, wraparound is a fundamental system reform effort. It is a way to kind of back into doing full-on systems of care. Because if you're going to do wraparound, you got to have, well, you've got to have eligibility determination and referral through no wrong door, ideally, right? That's a systems of care concept. You got to have a comprehensive service array, system of care concept, keeping kids in their homes and communities, which is what wraparound's all about, right? So doing this work with full implementation support is kind of like doing systems of care. And that's why it takes so long. It's an ongoing effort. You all want to add anything there? We can go to the next slide and see if there's where you all want to jump in. All right, go on to the next slide. So just summing up some more things, you know, that we've already said. System and organizational context is critical. Now we see this for other interventions out there in healthcare and behavioral health, but again, probably aren't many that are as dependent upon funding and policies as wraparound, right? The more complex the intervention, the more systems are required, the more complex the funding issues are, you know, so for complex EBPs like multidimensional treatment foster care, where you got to interact with the child welfare system and foster parents, for MST, where juvenile justice has to kind of agree that we're going to give control to the MST therapist for an amount of time. And, you know, kids have to get into MST, often as diversion, you got to pay for it. Those probably are also really system and organizational dependent. It's important for any EBP, and it certainly is for wraparound. So what we've done is that we've tried to define those structures. And so we have these coaching tools now. And these measures that help us stay on track. And so implementation plans should be tied to a continuous quality improvement agenda. So measure the degree to which you are achieving. So getting to Steve's question, whether you're a CMHC or a CME state or an organization within that state, you still have to figure out how to get your organization to be as hospitable to wraparound as possible. And we have a measure called the Wraparound Implementation Standards for Programs, or the WISP, or WISP, depending on what day it is or what we've had for breakfast. We might call it one or the other. But anyway, the point is that it has a checklist that, as part of our support, and it also helps us with our research, we're asking, how are you as an organization doing on these indicators of development for wraparound? So measuring that and doing coaching and technical assistance on those issues is critical to avoid, to promote good implementation. So Kobe and Kim, anything you want to add there about that process? I think it relates to Steve's question about what do you do if you're a CMHC state or you're an organization within a CMHC state and you want to do wraparound?
Yeah, I mean, I feel like you hit all of the points, particularly the connection to the wraparound implementation standards for a program. And I would just say that sometimes people use language and they talk about wraparound as being hard. I would say wraparound is actually not hard, but what I will say is wraparound is divergent from traditional outpatient practices. And I'm not saying we don't need those traditional outpatient practices. We do, we absolutely do. Evidence-based practices, the clinical work is crucial to the success of wraparound, but the actual act of doing it is just divergent. And so I think the things that you pointed out, Eric, around, really dedicated staff, dedicated supervisors, making sure that families have access to the provider array, a comprehensive provider array, not just what a community mental health center provides, are some of the practice standards that are outlined in the WISP. And there's a webinar coming up about that we'll tell you about at the end of this, which I guess we're almost there.
All right. So people are asking about the availability of that, and we'll let you know where you can go to get it. Another free webinar, this time under the auspice of the TA network and the Virtual Training Institute.
Yep.
So this will be a good kind of segue to that, which is only a couple weeks away.
Yep.
So stay tuned, but email us at that email that nwic@schoolsocialwork.umaryland.edu if you have more specific questions, but we'll give you the full scuttlebutt on the program and system level measures in that webinar as well. There was something else I was going to say. I've forgotten. Okay, go to the next slide. I did want to answer Nikki's question about outcomes. So like John says, we haven't examined outcomes in this kind of multi-level modeling from NWIC data, but a couple things to point out. One, we're launching this new data system that we're hoping many wraparound initiatives will use, called WrapStat, that will get some real basic information about outcomes. And we can link, essentially, what is your discharge disposition for each kid? Why did the kid leave wraparound? Was it because of success, meeting needs, or was it because of lack of engagement or placement or other outcomes? And I think that'll be an opportunity for us to look at the association between system and program factors, fidelity, and outcomes, because it'll all be in that one system. So anyone who's using the tools of our wraparound fidelity assessment system, that will be something that will be promoted by your being part of that. The other thing I will say is, even though we don't have outcomes in this presentation, because outcomes vary by state, there was no real good way to say, here's the consistent outcome measure we're going to plug into these analyses for every one of these 9 states. If you look at the individual studies of individual states that have used care management entities, like New Jersey, or some other states, you see these trends where expenditures for out-of-home placement just go down as they're bringing up of the process of doing wraparound using care management entities is advanced. And so although we don't have any controlled research or natural experiments like this, individual states have really found that this is a method that has worked in a way that could be documented in terms of shifting the triangle, so to speak, from most of the money going to residential to most of the money going to community-based services. And that's, I think, where we see a lot of the evidence right now is the most important thing. Like, how have states gotten to that redistribution of their resources and keeping kids at home? So the research is out there, but it's more open trials than controlled. So, but it's a great segue to the last slide here. Future work will include a larger sample of states, and we're going to bring, we need to bring outcomes in, and we are always at NWIC and at UW trying to find opportunities to do this kind of research. And because we only got a minute left, we should tell folks when that webinar on program and organizational support will be. So, there's the measure. So the measure, an example of the measure will be in the slide deck that's on the NWI website. But if you want the full the full skinny, here's where you go.
Yeah, the full skinny on those were just a sample of items in the tools, both the wraparound implementation standards for the system and the program, and the webinars Sarah and I will be doing for the Training Institute live on February 4th. And so I would encourage you guys to register for that and tune into that. And we can definitely share more information around those tools.
Yeah, if it hasn't been done already, you might want to put that URL to the Training Institute's live into the chat box so people can just click on it and then they'll see where to go. So maybe do that here before we end. There was questions.
Oh, okay, go ahead.
Yeah.
I was going to say there was a question, but go ahead.
I was just going to say, I think that this is a relevant question about, you know, do you wrap all this stuff up in a kind of example CQI or evaluation plan? We have some webinars, if you go to that webinar page, on the measurement model that all this is based on. It was, I think we did it in July of last year, 2020. And so it won't give you kind of a sample evaluation plan, but it will tell you about in much more detail what all these measures are and what they get at in our NWIC implementation efforts. So that's one place to go. But Belle, I also invite you to email me, and you know, we can talk a little bit more about what some resources you might take advantage of are. And there's my email in terms of CQI plans. Oh, so this is interesting. So Steve also has another question. One of my long-term questions is, the big motivation for WRAP at the beginning was money savings and lower RTC usage. What happens when WRAP has become more of the norm? Interesting question. Kim, do you have any thoughts on that?
Well, I mean, I guess one of my questions back would be, what do you mean by the norm? You know, I don't know if there's a real short answer to that, but I don't actually think wraparound is being used to its full extent or being leveraged in states the way that it should be. And I think that there should actually be more usage for youth going into congregate care or to divert youth from congregate care settings. We're still seeing really super high numbers of use of psychiatric hospitalization and residential treatment across the country, even though outcomes are super, super poor. And I do think that WRAP, people are sometimes installing WRAP in their system because they feel like they have to. And it's like, oh, we need this as part of our service array. And I would encourage you all to tune in on February 4th, because we're going to talk about how do we start to push WRAP back to that level so that we can impact some of those numbers and change that curve that we're seeing around the country. So I might not have interpreted it the way that you wanted me to, but that's my kind of plug for that.
Yeah, I would agree that it is a rare occurrence, if ever, that you see wraparound or other kind of community-based care being such the norm that, you know, we have found a way to somehow eliminate the need for congregate care. I mean, I think it's pretty well accepted that, you know, hospitalization, residential treatment have a role in systems of care and the service array for crisis response and stabilization. Mm-hmm. But it needs to be very short term, ideally, and supported from day one with a plan about how the youth is going to be successfully transitioned back home as soon as possible with adequate and intensive supports. And so I think there are very few states that have gotten to the point, even with, you know, those kinds of care options just being used for those kinds of purposes. Most states still have a certain segment of their population, if not huge swaths, that are still being probably unnecessarily sent to congregate care. And so I don't think we're there yet. But even if we were there, I think that you would still always have this quest to find a way to ensure that the youth with the most complex needs can live and thrive. And, you know, if you know, for those that you're just barely keeping at home, how do you get it so that they are, you know, succeeding in school as opposed to just being at home instead of, you know, in an out-of-home placement? How do you get them to have, you know, friends and lots of meaningful relationships and are thriving? So I think there's always going to be these questions, no matter where you're at in your system of care development, about how can we do better.
Mm-hmm. So we have another question around incorporating this into the Family First Prevention Services Act, which opens up a whole other conversation. But there is certainly information on the NWI site around inclusion of wraparound in a state's Family First Prevention Services Act. And I would say that as part of any comprehensive system of care, you would certainly want to have wraparound available to those youth with complex behavioral health needs, deep system involvement, at risk of residential again, and you know, that could be part of leveraging not only the child welfare system and the FFPSA, but also, you know, really expanding and partnering with your Medicaid friends and behavioral health and mental health and so on. But again, I feel like that's a much bigger conversation. But yes, we would certainly hope that this was part of a comprehensive plan and that it would be available for youth and families that need that level of care or that level of intensity, I suppose.
Yeah, ideally it's not, we're not creating silos of systems of care, right? It's not just within child welfare. The FFPSA kind of opportunity, like Kim is saying, brings folks to the table across the systems to talk about how do we create a comprehensive child serving system that spans all of the child serving sectors. Recognizing that, you know, the majority of kids in foster care or have been involved in child welfare have mental health needs. And same thing for justice involved youth. So taking advantage of that. And, you know, just putting in there the news, if you didn't know this, and you can go onto the NWI website to learn more about it, that wraparound is being reviewed now by the Prevention Services Clearinghouse for FFPSA. So it'll be interesting to see how that review turns out, what level of evidence they determine wraparound has. Even though we had 17 controlled studies that we found in our meta-analysis that John led and is about to be published, only a small number of those, or the minority of those, were child welfare specific, which means that the review by Administration of Children and Families around the evidence base for wraparound for kids involved in child welfare may not be quite as robust as for all kids, because again, they're looking at just one segment, whereas wraparound is really applicable to all of those kids probably. All right, I done with the Q&A. I think we've got it. I don't see any other questions. So I hope folks have enjoyed spending some time with us on Inauguration Day.
Yeah.
Any other concluding thoughts, Kim or Covey?
I would just thank you all for coming today. We're very excited to get this information out and disseminate all of these data and findings. And certainly reach out if you have any questions or follow up, that kind of thing. It was great having you all today.
And there will be a webinar, another webinar next month on that WrapStat system that we've created to try to support states and jurisdictions and wraparound provider organizations to use Fidelity and outcomes data to stay on track. So again, look at the NWI website to find that, and there'll be some information sent out through our listserv about that in the future as well. All right. Take care, everyone. Have a great rest of your day.